may not be applicable here because chromogenic factor assays are not widely practiced in our country. I'll show you that data much later. So just to talk about a revision for you probably about factor assay, one-stage factor assay. It's defined as the ability of various dilution of the test plasma to correct the APTT or PT of a severely factor deficient plasma and compare with the corrections obtained by similar dilutions of normal plasma. Now to refine that more, the ability of the test plasma to correct the PT or APTT of a severely deficient plasma, which is of course going to be very abnormal. So that plasma is called the substrate plasma. So the most important part of the assay. And compare it with correction with obtained on similar dilutions of normal plasma, where we expect all these factors to be 100%, including the substrate factor. So this particular plasma ideally should be a calibrator or a reference plasma. Now, coming to factor VIII assay, which is the most important part of this discussion. It is basically the ability of various dilution of the test plasma or the patient plasma to correct the APTT of a severely factor deficient plasma and compare it with corrections obtained by similar dilutions of reference plasma with known levels of factor VIII close to 100%. So when we do assays that we are known in the biochemistry lab, there is the optical density, which is the absorption along the y-axis and the concentration along the x-axis, and there's a nice linear graph, and you can see that the scale on the x-axis is linear and the scale on the y-axis linear. So this is a common graph paper that we use in biochemistry lab. It's mostly the assays which depend on color change and concentration of the substance. So commonly used graph paper for assays are lin-lin graph paper or linear graph paper, because both the x-axis and y-axis are linear. But when we use the same graph paper for factor VIII assay, this is the line that you get. Now it will be very difficult to analyze what is the level of factor VIII for the endpoint that is detected. So because, for example, from 0 to 10, you'll find that it's almost everybody is close to normal. But when you come to 20 to 120, the endpoint is almost similar. So this particular graph needs to change. So we realize that the activity that we are measuring is by the activity part of factor VIII. And we realize that all biological activity of any protein has to be linear only in the logarithmic scale. So we need to convert this linear graph paper to accommodate logarithmic scale. So now if you look at it, this is a log-lin graph paper where the biological activity of factor VIII is along the x-axis, while the timing or the endpoint is along the y-axis, which is linear. So this is a log-lin graph paper. Sometimes it's also a good idea to have the plotting time, which is on the y-axis, also as a logarithmic scale. Doesn't make much of a difference, but you can see that the funny graph that we had earlier is now converted into a sigmoid. A parabola has been converted into a sigmoid shaped graph. Now here, obviously, it's still not the same as what we saw in the glucose assay, but here we can harness the straight part of the sigmoid graph. So you can see that somewhere from 1 in 10 dilution, which is considered to be 100%, to about 4%, that is close to about maybe 1 in 150 dilution, is where the straight line of the sigmoid graph is. So if we can harness that particular part, then we can at least get some linearity in assessing the biological activity of factor VIII. So that's why this logarithmic scale is very important, especially for the biological activity. Now there are certain rules for factor assays. Now the graph that we see on top is basically the graph of the calibrator or the reference plasma. 3 points or 3 dilutions are good enough. But when you are going in for automation and sometimes even manual method, there's no harm having an extra dilution. Maybe at 1 in 5, that is a lower dilution, or you can have higher dilution. But whatever is the dilution or number of dilutions you use, this dilution should be connected with the best fit line, which connects all the points along the best fit line. It may be slightly away from it, may not be on the best fit line, but not far away from the best fit line. If it's very far away, then there's a problem with that dilution. So all the dilutions, which basically reflects the concentration, because as you dilute the plasma, you get different concentrations of factor VIII. And when they are assayed, they should be connected by a straight line. So that is rule number 1. Second is the patient plasma also should be serially diluted, not single point. It should be diluted, at least 3 dilutions for sure. That is the 1 in 10, 1 in 20, and 1 in 40, which is commonly used. Some people like to use 1 in 10, 1 in 50, and 1 in 150, because 1 in 150 comes close to the 4% mark. So sometimes it may be good to use higher dilution, but whatever it is, patient sample should be diluted 3 times. So second rule is that patient dilution should also be connected by a straight line or a best fit line, where the points are not far away from each other or from the straight line. So that's rule number 2. And rule number 3 is that both these lines should be parallel. If they are not parallel, then there is a problem or there is some interference in this assay, and you may have to look at that before you give the result. So rule number 1 is all the calibration points should be connected by a straight line. Patient dilution should be connected by a straight line, and these 2 lines should be parallel, which is also indirectly called as parallelism. So when you say parallelism, that means the patient plasma has been diluted. Three dilutions have been made. Serial dilutions have been made. So what are the reagents you need? You need a reference plasma, which is to draw the standard graph, the first graph that I showed. Most of these reference plasma are available commercially. For example, there are main companies like IL, will call it as calibrator, IL calibrator. Stego will call it Unical, and standard human plasma is what is mentioned by Siemens. But why are they called calibrator? Is because they are traceable to the international standard, either WHO or the SSC standard. You can make reference plasma where all the coagulation factors should be close to 100% by making a normal pool plasma or a pool normal plasma. We can pool about 20 normal people. But you call them a reference plasma, in-house reference plasma, only if you have assigned a value with the help of a calibrator, so that it is traceable to through the calibrator to the international standard or the WHO standard. If you don't assign that, you can probably assume that the pool normal plasma may have close to 100%, but it's a fairly rough estimate. We noticed that healthy blood donors in our country, even if they are O group, their factor VIII levels are on the higher side. So pool normal plasma made in our region will have those values close to 120% rather than 100%. But it's not that far away. While if you get the pool normal plasma in any of the labs in Europe, it will be usually less than 100%, close to 90%. Their factor VIII levels are not that very high. So don't assume that it's 100%. It's a good idea to assign the value to the in-house pool normal plasma. Then, of course, you can have control to make sure that your test is having proper validation. Then you have the test plasma, and of course, the substrate factor VIII deficient plasma. Now, factor VIII deficient plasma also can be obtained in-house, obtained commercially, or it can be made in-house from a voluntary severe patient with severe hemophilia who volunteers to donate some of his blood, create factor VIII deficient plasma. Then you have the serially diluting buffer for serial dilutions. Then you have nowadays it's mostly imidazole buffer because barbitone buffered saline is banned because barbiturate is a banned substance. Though the barbiturate buffers are available commercially as Oren's Veronal buffer, make sure that the pH is between 7.35 to 7.4. Then you have calcium chloride, and then you have the APTD reagent to create the one-stage APTD based assay. So these are the dilutions that you had already done. So I'm not going into the details of it. After you do the dilutions, then you incubate it with factor deficient plasma. And then you add the APTD reagent, incubate the APTD reagent with the mixture of the dilutions and factor deficient plasma. And after 3 or 5 minutes, you can add the calcium chloride and look at the endpoint, which is the formation of the clot. And plot the values of the endpoint on the semi-log graph paper. So as I said, there are 3 rules. The calibrator should be, or the standard graph should be connected by, all the points should be connected by a specific line, which is a straight line. The patient's dilutions, the 1 in 10, 1 in 20, 1 in 40, should also be connected by the best fit line, and these 2 lines should be parallel. So let's look at some example here. So we have got some timings obtained. So here in our place, we do 1 extra dilution, 1 in 5, which is equivalent to true 100%. 1 in 10 is close to 100%, 1 in 20 is 50%. So now at least you realize why these 1 in 10 is close to 100%, because you can see that that's the best part of the sigmoid. So we take that 1 in 10 dilution as 100%, 1 in 20 as 50%, and 1 in 40 as 25%. So these are the endpoints that we detected. So can we plot them on the graph paper? So you have 43.5. I think that 40 has fallen a little below, but 43.5. Then 50, that's 1 in 5 dilution, which is 200%. For 1 in 10 dilution, you have 51, which is just along the 1 in 10 dilution. You can see 1 in 10 dilution there, which is 100. 51 is just above the 50. Then you have 59.5, which will be close to 60 seconds. And you have to go at 50%. So that is 55 at just above 5. You have got 59.5, which is close to 60%. Then you have 66.5, which will be between 60 and 70. And 25 is between 2 and 3. You have 25. And then you can see that there is this 66.5 seconds. So now this is the standard graph. And this is the dilution of the standard. And you can see that the best fit line definitely connects the first 3 points. The fourth point is slightly away, but it's not very far away. So this is the best fit line for the standard graph. Now patient will be 66 for 100%. For 50% is 74.5, which is the point between 70 and 80. And then you have the 83 for the 25% of the patient's plasma. And that also is connected by a straight line. And these two lines are parallel. So I now say that my assay qualifies very well because I have achieved all the 3 rules for the one stage APDD based assay. Now to find out the value, the 100% value of the patient, I take the 100%, that is the 1 in 10 dilution timing of the patient, cross the standard line, standard graph, and then drop it down to find out how much value I obtain. So you can see that it is between 20 and 30. So you can say that's between 25 and 30. So probably 27 percentage is the 100% value of this patient. So it looks like he's a mild hemophilia. But that is not enough because now you'll have to go back and see whether there's any calibration factors involved. So we know that the calibrator value that was used was 89%. But we assumed that everything is 100%. From 1 in 20 for the calibrator, 1 in 10 of the calibrator is 100%, 1 in 20 of the calibrator is 50%, and 1 in 25 dilution is 1 in 40 dilution is 25%. But here actually the 100% value is 89%. So the 1 in 10 dilution value should be 89%. The 1 in 50 should be half of 89%, and 1 in 40 should be 1/4 of 89%. But we didn't want to bring in all decimals, so we assume everything is 100, 50, and 25. But we will bring in the calibrator later on. So that's not the calibration factor. So now the calibration factor is going to be 0.89. So you multiply the value obtained of the 1 in 100, which is 27, by the calibration factor, and you get a value of 24.03%, which is the final result on this patient. So all these rules have to be followed when you're doing a one-stage factored assay. Now, many of these assays can be automated into machines to reproduce the manual technique, which I think all of you did the manual technique. Variables involved in manual method are eliminated, but probably I think Dr. Bipin and Dr. Rucha may have made you do the PT and APDD manually, but the factor assays, they have used the semi-automated machine, which I have seen them use in the workshop that they conducted in Bhopal. So calibrator is the advantage of automated assay is that calibrator is done only after major servicing, change of lot of reagents or buffer or deficient plasma. But make sure that the controls are run definitely during the factored assay. And the advantage of that, you can have a low curve and a high curve when you have extremes of factoring. Critical point for the factor deficient plasma. This is always a critical point. Of course, I'll come to show that there are certain other critical points which have started coming or have been exposed because of the modified factors that are coming up. So factor deficient plasma is, you must realize that's a plasma which has got the fibrinogen, which is going to clot. It has got the other factors in adequate amount, which is going to clot, because nothing else is going to clot. So it is a factor deficient plasma which is going to determine the end time. So it should completely lack factor VIII. It should not contain any inhibitors, It should contain normal concentration of all the other coagulation factors, especially fibrinogen. Ideally, it should contain normal concentration of von Willebrand's factor and negative for viral markers. There are limitations for one-stage factor assay, and that is where we start our story for today. Susceptibility to interference from pre-activation of factor VIII or antiphospholipid antibodies. So this can happen that you don't collect the sample properly, or you transport the sample in cold, not in ice. Ice means not even ice, and not in frozen. It's transported in cold, which lead to cold activation of factor VII. Usually happen 5 hours from the time it's kept in cold. And factor IX will get activated 5 to 6 hours, 6 to 7 hours after it remains in the cold. Then, of course, there can be misleading results when assaying infused recombinant factor VIII. I'll come to that. And of course, there are certain factor VIII mutations which causes mild to moderate hemophilia A, which will be normal in the one-stage factor assay. But when we do the chromogenic assay, they will reveal the mild to moderate stage of, and these patients are symptomatic. Symptomatics like mild to moderate hemophilia, they have symptoms of mild to moderate hemophilia. Aptt is normal. One-stage factor VIII assay is also normal. But when we do a chromogenic assay, you find that they are mild to moderate hemophilia. So this is called the discrepant hemophilia. So that's where the chromogenic became very popular. So now what was happening is, as people were gaining knowledge on the recovery assays, especially when recombinant factor VIII assays came. This even happened when there was, intermediate purity and a high purity factor VIII concentrate. It was found out, or retrospectively also identified, that the one-stage assay is underestimating the factor VIII that was infused as per calculation by 20 to 30% compared to chromogenic assay and a two-stage factor assay. Two-stage factor assay is not frequently done because it's manufactured only by one manufacturer, and it basically it's not as easy to automate it. But we realize that chromogenic assay is basically replicating the two-stage assay, but the endpoint is not a clot but a chromogenic substrate. So what is happening in the chromogenic assay? It is also a two-stage process. The initial step is to produce factor Xa in a quantity proportional to the amount of factor VIII present in the patient. So the factor VIII will combine with factor IXA and convert factor 10 to produce 10A. So that is entirely dependent on how much factor VIII is there, because all the 9A is already well known how much 9A is there. Based on the 8 is 8 present, and there'll be a little bit of thrombin there, because thrombin will convert the factor VIII to 8A. That will allow the formation of the complex, the 10A's complex, where the 10 will be attached to the 9A and 8A, and they'll convert 10 to 10A. So it's entirely dependent on how much of factor VIII is there. Now, the second step is where they use the Na produced to act on a substrate, which is a chromogenic substrate, and then it produces color. So the color is directly proportional through the second step and the first step to the amount of factor VIII that is present in the patient. So the reason why this may have happened is that people thought that because factor VIII concentrates are assigned potency based on chromogenic assays. It used to be by two-stage assay, but now most of them by chromogenic assay, especially the recombinant factor VIII, because these are predominantly in European countries. So European countries, they actually assign potency using chromogenic assay. So probably that is the reason why the one-stage assay was underestimating the amount of factor. Then somebody came out with a brilliant idea. That is Trevor Barrowcliff. He was working as the head of the National Institute of Biological Science and Control near London, which produces all the international standards. And he said that there is something called the like versus like principle. Can we adapt that? So the like versus like is like this. When you infuse factor VIII concentrate into a patient with severe hemophilia A, the patient with severe hemophilia A is something like factor deficient plasma. So into that, you are infusing factor VIII concentrate. So he said that, why can't we take factor deficient plasma, add a little bit of factor VIII concentrate, just like we have calculated for the patient, let's make it 100%. So you dilute the factor VIII concentrate into a factor VIII deficient plasma, then you have 100% of factor VIII. It's almost like the patient being infused with factor concentrate. Now with the factor VIII deficient plasma, which has been spiked with factor VIII concentrate to a level of 100%, now you have a normal standard plasma where factor VIII has made the factor deficient plasma 100%. Now use that to create the standard graph. So once you create the standard graph, that is 1 in 10, 1 in 20, 1 in 40 dilution, and then you assay the patient, you find that this particular problem with one-stage factor assay does not or gets eliminated. That means whatever chromogenic assay results you get, the same assay results you will get with the one-stage factor assay. So that's why there is something called a factor VIII concentrate standard also available from NIBSC. You can use that standard to create the standard graph, and of course you can use a one-stage factor assay. I realized over a period of time, this article was published. He's written a few articles based on that. Only we adapted this method, and we found this method absolutely useful. We were doing chromogenic assay, but chromogenic assay in our country is far more expensive than a one-stage assay. In Europe, I think basically because of pricing, they don't find much difference in the one-stage assay and chromogenic assay. And one-stage assay automation is a little bit more challenging than a chromogenic assay. So therefore, they don't do one-stage assay. And this like versus like principle was never practiced. So nobody has data on like versus like principle. That's why I always wondered in factor VIII and factor IX subcommittee, there is a discussion on one-stage factor assay and a chromogenic assay. Nobody talks about the like versus like principle. So I think this like versus like principle is very useful till you start using chromogenic assay. Now chromogenic assay, we were using it only to find out any issues related to our results of the recovery assay, which is done by like versus like one-stage assay versus what was calculated. So you must realize that a lab which is accredited, which is participating in a good request program, is very and assign values for NIBSC standard, is fairly confident about their quality. Now, when they give a result out, it is understood that whatever factor VIII was in the sample is the value that you obtain. So, but when they say that no, we wanted to give 100%, you have given a result of 45%. So you must realize that there is something that you need to clarify before you repeat another assay. Was the sample collected properly? If the sample is not collected properly, you will have a problem with this. Has the potency of the factor concentrate that has been given, is it within the expiry period? Because many of our centers, we use factor concentrate which are beyond expiry. They work very well, no doubt about it. And if it's beyond the expiry period, has its potency been checked? So these questions have to be answered before you repeat another assay. Otherwise, you ask for a repeat sample, because you must realize an assay is as good as a sample. If the sample has been badly collected or has bad content, you're not likely to give a result that they expect, because these pre-analytical considerations have to be really considered. So like versus like is as good as chromogenic. So adopt chromogenic only if you think it is mandatory, or if you cannot do anything else other than chromogenic assay for certain factors. So now you have newer products that have come, especially the extended half-life products. So, we always assume, extended half-life product, what is the problem? It's only anyway factor VIII only. But we realize that they have modified the factor. They have pegylated the factor VIII. They have done certain other carboxylation modification to the factor VIII. That the factor VIII is no longer the same factor VIII, but functionally it is the same. In vivo, it's the same, because it's able to achieve the hemostatic effect, or the stopping the bleeding effect on patients, or preventing the bleeding in patients with severe hemophilia. And then, of course, there is a molecule which is behaving like factor VIII. So what is the job of factor VIII? Factor VIII is to create the 10A complex, bring factor 9A close to factor 10 so that it can activate factor 10 to 10A. That's why it's called the 10A complex, because all enzyme complexes are named after the substrate, and here the substrate is 10. So 10A complex. So what is it? It's basically a humanized bispecific antibody. One side of the antibody is specific for factor 9A, and one side of the antibody is specific for factor 10. So it brings in both next to each other, almost like factor VIII. So even without factor VIII, it behaves like factor VIII. So what info does extended half-life product bring to factor assay? Because till now we were saying the most important part of factor assay is the factor deficient plasma. Now we slowly realize APTT reagents being used for the factor assays are not to be ignored because their contents can actually affect the assay. Like, there are APTT reagents are very varied. They can be varied because of the contact activator that's given, ellagic acid, silica, and kaolin. Though we till now have been talking about APTT reagents either being factor sensitive, heparin sensitive, or lupus sensitive. But as far as this is concerned, now you should know whether your APTT is ellagic acid based, silica based, and kaolin based. And silica also, whether it is micronized silica or whether it is colloidal silica. Even kaolin also, it's whether it is colloidal kaolin. All this information is very important, especially if you're in a center which is treating patients with hemophilia receiving extended half-life. The phospholipids become very important, especially in antiphospholipid syndrome, because there mostly 3 phospholipids are used in the APTT reagent: phosphatidyl serine, phosphatidyl inositol, and phosphatidyl ethanolamine. These are all negatively charged phospholipids. The significant part is phosphatidyl serine, because changing the concentration of phosphatidyl serine can make a huge difference between factor sensitivity and lupus sensitivity. So they don't usually change the concentration of phospholipids to make it antiphospholipid insensitive or lupus insensitive. They only change the concentration or the composition, not the concentration or not the quantity. So all this now started becoming important because we know that phospholipids are where on the surface of which the tenase complex and the prothrombinase complex will form. See, these complexes will only form in the presence of anionic phospholipid, calcium, and then of course these coagulation factors. For example, here you can see the tenase complex requires the phospholipid, and the prothrombinase complex also requires the phospholipid. So APTT reagents have been generally been selected for either factor sensitivity. We like really factor sensitive reagent, heparin sensitivity, and we don't like lupus sensitive reagent because our job is not to look for lupus in the population. Lupus sensitive, when the sample comes for lupus test, then we will probably use a lupus sensitive reagent only to do lupus test. So we realized that the lupus insensitive reagent is not because the phospholipid quantity has increased, but it's purely because it is changing the phosphatidyl serine in the composition, especially in reagents like actin-FS. So we now realize that yes, phospholipid composition is very important in making for factor sensitivity or lupus sensitivity. But now we realize that looks like activators are also involved in the variable, not only the phospholipid. It was discovered that because of pegylation, sometimes the enzyme complex can form on particulate activators, especially silica and kaolin. Now, because these enzyme complexes are forming, not enzyme complex itself, the complex with the factor 8, complex with the factor 9, complex with factor 10, or it can have an entire enzyme complex on the surface of the particulate activator. So either they get consumed or they are prevented from participating in the complex formation, which leads to underestimation of the infused factor. So whatever concentration we have calculated and given, when we do the recovery assay, you find that you get lower values. And then you have a possibility of activation during this process, and you will get overestimation. So both problems do happen. Now, though pegylation does not affect the biological activity of one of these products, N8GP, but may affect the factor 8 activity assay. So let's look at the one-stage clotting assay. The majority of the APTT reagents show acceptable recovery of this factor extended half-life product. However, 3 silica-based APTT reagents, which are particulate contact activators, underestimate the N8GP factor 8 activity. Chromogenic assays, several chromogenic assays, especially which are the Quatest, Quamatic from IL, and Biofen, which is from Hyphen Biofen, they slightly overestimate the factor 8, extended half-life factor 8 from Novo Nordisk. Now, other pegylated recombinant factor 8 products, like the Bayer project product 7949027, were underestimated at all concentrations when using silica-based reagents. So reduced factor 8 activity was observed when APTT SP and STA PTT automate reagents were used to measure factor VIII deficient plasma spike with this particular extended half-life product with the WHO 8th International Reference Standard. However, Actin-FS and CK-Prest, which are not silica based, but CK-Prest is kaolin based, and Actin-FS is ellagic reagent based, showed some overestimation of Bay 979027 activity. So, possible explanation is that the chromogenic assay is likely to be relatively insensitive to pegylation due to its more stringent activation condition. And the overestimation due to premature activation triggered by PEG-mediated co-localization of N9GP with factor 9A and plasma kallikrein on silica particles. So now we realize that complex formations are possible on particulate activators. So this is one of the pegylation interferences with one-stage clotting assay. You can see that all the non-particulate contact activators were able to not overestimate. The blue are all non-particulate, non-silica based APTT reagent. But if you look at all the silica based APTT reagent, you can see that there is a far more overestimation than what is done by non-silica based reagent. The chromogenic assay at the same time was almost similar to the non-silica based APTT reagent, which is in green. So the same problem happened with extended half-life products related to factor 9. There was overestimation of the pegylated factor 9 activity, and we saw that it is because of co-localization on silica particles of the enzyme as well as the factor 9. Summary vis-a-vis the extended half-life products, there are challenges and uniqueness with different EHL factors. Reagents react differently to specific molecules, leading to over and underestimation. One needs to be mindful of the appropriate reagents in case monitoring is done to avoid under or overdosing, which basically means unnecessary loss of the drug. Most importantly, the unique reagents that are applicable for EHL factors are readily available in India, and it isn't a challenge. Now let's come to Hemostasis. We can see that here the activity that factor VIII is doing to create the tenase complex to produce 10A, the same thing is being done by Hemostasis. So Hemostasis is doing a factor VIII activity or factor VIII-like activity, because I can't call it factor VIII activity because it's not factor VIII. It's factor VIII-like activity, but exactly like factor VIII. So what are the things that we need to keep in mind? Hemostasis is effective in hemophilia like factor VIII. However, with patients with inhibitors, it's still effective compared to factor VIII. Factor VIII, if you are giving a concentrate to patient, infusing a concentrate to patient, it will have peaks and trough, while Hemostasis doesn't have any peak or trough. The factor VIII concentrate is an intravenous dosing, while Hemostasis is a subcutaneous dosing. Subcutaneous dosing has its variability, but they find that there is no issue with that. So what are the differences between factor VIII and Hemostasis? The mode of action and regulation of Hemostasis is very different from factor VIII. In addition to being able to bind to factor 9A and 10, Hemostasis is also capable of binding to zymogen factor 9 and also the enzyme factor 10. Hemostasis does not bind to phospholipid surface and also as a bispecific antibody. Hemostasis is not regulated by activation and inactivation mechanism that regulate factor VIII activity. As I saw, the tenase complex requires phospholipid. The recommended treatment regimen results in stable, prolonged levels of drug with a described half-life of approximately 30 days, and therefore it persists in circulation many months after the last dose. So, laboratory monitoring is to level of the therapeutic agent, monitoring the effect of non-factor therapies on hemostatic potential of the patient, and monitoring the factor VIII equivalence of non-factor therapy. So, when we use unmodified factor VIII assay, we find that it's unsuitable to measure Hemostasis, because if you look at it, all these APTT reagent, that is actin, pathrombin, actin FSL, actin FS, they all are giving values unimaginable factor VIII values, almost like 1,000, 1,200, anyway more than 200. Everything is more than 400. 400% of factor VIII-like activities, almost a thrombotic level. And interestingly, it is compounded by a normal APT. All these patients, when you do an APT, it's not abnormal, it's normal. So monitoring levels of this therapeutic agent, because it mimics factor VIII cofactor function, it's possible to use factor VIII activity assay to monitor emicizumab, which we realize now it's not possible. So unfortunately, it is not possible. And we also know that APDT is normal even at a very low level of emicizumab. So effect on patients' APDT and APDT-based coagulation assay may be evident for up to 6 months after treatment discontinuation. So if patient has been anywhere close to emicizumab, these two parameters are of no use. Routinely used chromogenic assays were not able to reflect the factor VIII-like activity of emicizumab. So that is something that is also concerned. So routinely used. I'm talking about in India, we get chromogenic assays from either Stego or from IL or from Siemens, Sysmex. None of these routinely used chromogenic assays were of any benefit. And we found that not normally available vendors in India, Hyphen Biomed and Rosix, they also produce chromogenic factor assay. But they are different from the routinely available chromogenic assay in our market because they are having the source of factor 9 and 10 from humans, and while the others have from bovine. Now we realize that emicizumab is an antibody which is humanized. It will only bind to factor 9 and factor 10, which is human and not bovine. So that's why the routinely available chromogenic assays were not able to pick up the emicizumab activity. So we need to buy these specifically available chromogenic assays. So this is the data from Steve Kitchen's lab, where he found that the Hyphen Biomed, which is a human factor 9 and factor 10, was able to reflect emicizumab levels compared to all the others which had bovine. In fact, ecloclone is half bovine, half human, but again, it was not able to reflect the emicizumab activity. So Siemens, Coematic, Coates, these are commonly available in our country, but Hyphen, you have to contact them directly and obtain it directly. And Rosix also, not difficult. They have their some preferred vendors in India, and they do use them to sell these products. So you can realize that the emicizumab activity, which has been detected by Hyphen Biomed, where the activity of factor 8 is reflected by use of emicizumab, which combines with factor 9A and factor 10, which is of human source. So it's almost like reflecting factor 8-like activity. So this is an assay, a chromogenic assay, which is human-based, which reflects emicizumab factor 8-like activity. So here you can see that one-stage assay, as I showed you the graph earlier, everything starts at 200% based on the amount of emicizumab concentration that's there. But if you use a chromogenic assay, which is human-based, it reflects the emicizumab activity directly proportional to the amount of emicizumab. It's a beautiful correlation between emicizumab and chromogenic factor VIII assay, which is human-based, while bovine is absolutely a flat line, not reflecting any activity at all. How do you monitor emicizumab? Chromogenic factor VIII assay, which is human-derived, and you report the activity like factor VIII assay as international units per deciliter, which is same as percentage. There is another measuring mode, which is a modified one-stage clot-based assay using an emicizumab specific calibrator, which is reported in micrograms per ml. So this is what is available, which is manufactured by R2 Diagnostic, which is same as enzyme research. The product insert will tell you that this is a product which has been made by spiking factor deficient plasma and assigning a value after a calculated value, and then also assaying the value. The value of the emicizumab calibrator has been assigned. It usually not be close to 100%. I think in this particular vial it was some 95%. And they also that's a calibrator, and they also make controls again by spiking 2 different levels of emicizumab on the factor deficient plasma. So level 1 and level 2 control. So the modified one-stage assay were made exactly like the factor assay that we discussed just now. So we use the calibrator to make the standard graph. We use the test plasma, which contains emicizumab, which has been infused in the patient. And just like factor assay, the multiple dilution, we follow the 3 rules: straight line for standard, straight line for patients dilutions, and parallelism. So this is a study that showed that irrespective of the reagents that were used and irrespective of the machines that were used, there was a good comparison between the modified one-stage assay across reagents and platforms. So this is something that we did. We compared the chromogenic biofen assay with the, this was a pilot 2 patients with the emicizumab factor rate against emicizumab. The factor rate biofen, we always call it as emicizumab factor 8-like activity, while the other modified one-stage assay is emicizumab. That is emicizumab level of, but it's not percentage. It's not mentioned as percentage because the value assigned for the calibrator is micrograms per ml. We can only use what is the value that is mentioned in the calibrator. So you can see that there is a good comparison between the chromogenic assay, which is human related, compared to the factor assay, which is a modified factor one-stage assay with emicizumab calibrator. So emicizumab calibrator is not very expensive. So if you use this calibrator and do the one-stage assay, which is modified one-stage assay, you need not have the chromogenic assay, which if you're forced to buy a chromogenic assay, you have this alternative to do the modified one-stage assay with using the emicizumab calibrator. So there are other platforms which can be used to measure the hemostatic potential of the patient. So that is global tests like clot waveform analysis, thromboelastography, thrombin generation test. So you can see that. But one thing was there, the thrombin generation profile appears to be ameliorated in the vast majority of patients that receive emicizumab. Only thing is, we need to correlate it with the levels versus the clinical efficacy. So limitation is yet clear how well the individual thrombin generation potential in vitro correlates with actual hemostatic response in the patient. And these global assays will not give information about the true factor rate equivalence of the agent. Now, in addition to these limitations, I'll show you the data from the first program that we conduct, the proficiency program we conduct. We have 90 registered participants, only 87 centers because many of them use different platforms for factored assay. This for factored assay. 31 are private laboratories, 36 are attached to medical colleges, 20 are in the government, and 10 are registered from Gujarat. So you can realize that how many centers will be able to offer service to patients related to factored assay. This is one-stage factor assay. I'm sure the chromogenic will be probably 4 or 5 centers in our country. So I think from the beginning, we have seen that there is significant improvement in participants for factored assay, which is very encouraging. So I'm probably in a short time, because of these pressure from the service that we need to provide to the patient, probably these assays will slowly come into our country and service will be available for them. So thank you very much for your attention. I'm willing to take any questions.
Thank you, sir, for that excellent and informative lecture. We will now take few questions. The online participants can type it in the chat box. Anyone from here has any questions? Can you come here?
Good morning, sir. Sir, I have a question. So, like when we are managing a patient of hemophilia who is on emicizumab or on extended half-life products, so what is the implication of routine PT-APTT INR testing that we do? Is that altered when we use this?
So the thing is, there will be, thing is, you must realize in factor assays, we are diluting the patient's plasma. So the dilution will probably overcome some of these effects. But APTT will definitely be affected. So if you're going to use silica-based APTT reagent, you will get the APTT not reflecting the amount of the extended half-life product that's there. Because if you generally give factor infusion, if you are achieving 50% of factor rate, APTT generally will be close to normal. So when you are using extended half-life product, it's good to have another reagent. Allergic, the safest would be allergic acid, though kaolin-based reagents, which is also particulate, has not shown any issues, except for some of the products factory recombinant products which was being manufactured by Baxter. I mean, now it's not Baxter, it's Takeda.
So, like as a clinician, should we like whenever we send a patient, if that patient comes back with bleeding or like comes back, we think that the patient is not responding or like some alternation in the clinical behavior of the patient. So, any like thing we should keep in mind that it can either be a lab error which might be coming because the patient, like the lab might not be using a like special reagent which will pick up the patients having on extended half-life product or eculizumab. So anything that we as a clinician should keep in mind that when our patients are on these therapies, what tests specifically we should ask in labs?
So labs which are used to providing service for patients who take, I mean, for physicians or pediatricians who take care of patients with hemophilia, they are used to asking the lab, I mean, the physicians or pediatricians, that is this patient on a different set of factor concentrate. So once that is done regularly, the physicians or pediatricians will usually send the product insert of that new product along with that. In the product insert, it will very clearly mention what assay works and what assay doesn't work. So it's usually mentioned. Now, if you're a very good comprehensive healthcare center, when such a product comes into the market or it's going to be acquired by the center, it's a good idea for the center to inform the lab that this is going to happen, because you can't get a reagent overnight. It needs at least 2 weeks for getting a new set of reagents.
So there's one question in the chat box. Roche analyzer, will it be okay for chromogenic assay for patients on emicizumab?
Absolutely, no issues.
Okay. Any other questions?
Is Roche analyzer available in the country? I thought they're not marketing it actively. It's called the Cobas 511 or something like that.
I think they have it. That is why they asked.
Okay, fine.
Okay. Okay. If we have a choice, should we prefer chromogenic assay over one-stage clot-based assay?
See, the choice is entirely dependent on whether you are given fund to take the chromogenic assay. See, thing is, chromogenic assay. See, as I told you, we have shown multiple ways in which you can avoid a chromogenic assay. So I have never found chromogenic assay as the fact that, oh, I can only do chromogenic assay. Like versus like principle allows me to overcome chromogenic assay. For me, the only way is I need a chromogenic assay if I need to do a inhibitor test on a patient on MS. That's the only time I need a chromogenic assay. Otherwise, I don't think so. I'm that worried about a chromogenic assay, because I've got at least 3 chromogenic kits in my lab. But when a sample comes, they come to me, and I am very critical about, okay, you use this test. If this test is less than 1%, don't do the other chromogenic assay. I'm very careful. So yes, given the choice, I will look at what are the other options that are possible before I go. I mean, I've been using chromogenic assay from 2003. I have never found it as, yes, this is the assay to go.
Okay. Thank you. There are any more questions? Okay. So, sir, I would like to propose a hearty vote of thanks on behalf of ICMR NIH for accepting our invitation, and we look forward to many such interactions. Thank you so much, sir.
Thank you.
Okay, so before moving ahead to our next session, I would like to announce that a link for an MCQ test sheet based on all these lectures will be emailed to all the participants who have registered. I request all to play the quiz and submit the form. Those who submitted would get the right answers emailed back to them the next day. So with this, we have 5 more minutes for the next lecture. We will begin in 5 minutes. anyways, I'll go ahead. So we have our next lecture on difficult cases in a hemostasis laboratory by our very own Dr. Shrimati Shetty. I would like to introduce ma'am. So apart from being the pillar of our department, our mentor and guide till date, she is presently the director at the Laboratory Hematology and Clinical Research at KJ Somaiya Medical College and Research Center. She is ex-scientist F, senior grade deputy director of ICMR NIIH. She is the ex-director of International Hemophilia Training Center, World Federation of Hemophilia. Her area of expertise is hemostasis and thrombosis, molecular biology, and maternal and child health. She has won several awards, few of them being the Young Scientist Award, the Hiranandani Award, and the list just goes on. She has been a national advisor in the Indian Journal of Hematology and Blood Transfusion and is a member of many excellent groups like Mumbai Hematology Group. She has guided 2 postgraduate, 7 PhD, and 4 postdoctorate fellows. She has several projects as principal investigator and principal co-PI. Extramural were 20, international 3, and many more, as well as co-investigators. You can see how many publications. There is 262 publications, and she has 2 patents. So with this amazing and excellent CV, I would like to now hand over the screen and to ma'am.
Thank you, Rucha. And can you all see my screen?
Yes.
Can you all see?
The screen, yes.
Yeah. Okay, 1 second. All right. So I am a guest speaker today to NIIH, but I have joined KJ Somaiya Hospital, and I always take pride in being a part of NIH at ICMR NIH at KEM Hospital. I have spent my entire career in NIH and probably half of my lifetime there. I learned ABCD of blood coagulation under 2 stalwarts, Dr. Deepika Mohanty and Dr. Kanjaksha Ghosh. So NIH is always a place which I take pride in. So today I'm going to talk on, not on a regular topic, but I just want to present before you some of the unusual cases what we have encountered at ICMR and NIH during probably over the last 20 or more years. Now, if you see here, on several occasions, we get cases with factor 8 and factor 9 both being low. This has become a problem for us when we screen samples what we receive from the camps. You don't have any family history with you. You are just processing a sample with factor 8, factor 9, both being low. On many occasions, we receive reports from patients, specifically from private labs with such reports, because whatever they get, they just process. They've been asked to do factor 8 and 9 assays. They do that without any clinical background. They issue the reports. This is the strategy in the private labs. But as an academic institute, you know that you can't have both deficiencies, though it is possible, but that is not a regular case what you get. So how do you sort this out? You don't have any clinical background. Your Bethesda assay is inhibitor positive. So how do you offer a diagnosis? So the first thing what you need to do is, if you have an access to the family history, you just find out whether you have another case in the family. If there is another case with hemophilia A or hemophilia B, then you easily come to know that this is a case of factor 8 deficiency, and there is some specific inhibitors which is reducing the factor 9 as well. Now there is another method to do that, to see that it is, to look into the specific deficiency of the factor. That is, you generally do 3 dilutions for your factor assay. I am not very sure whether people do 5 dilutions, but generally we do in our lab 3 dilutions. And you go for extended another 3 dilutions. You go for further dilutions. And as you do these dilutions, your factor 8, if it's a case of factor 8 deficiency, your factor 8 will remain less than 1, but your factor 9 will start increasing. So this is how you come to know that it is a lupus-related multiple factor deficiency in a case of congenital factor 8 deficiency. So this is a case 2 in which a 10-year-old boy, non-consanguineous parents, presented with IC bleed with previous history of bleeding from multiple sites. So the patient has a definitive history of bleeding. So as soon as a patient comes, you do the primary screening assays, PT, APTT, and TT. In this case, both PT and APTT are prolonged. TT is normal. Rest of the factor 13 is normal. So among the first few screening assays, both PT and APTT are prolonged. So as per the strategy, when both are prolonged with the definitive bleeding history, you look for the common pathway factors, that is factor 10, factor 5, factor 2. Now, depending on the commonality, you take up the first factor, that is factor 10. Factor 10 is normal, factor 5 is 23%. So are you going to confirm the diagnosis of factor 5 deficiency here? Or are there any other conditions where factor 5 can be reduced as well, where PT and APTT can be prolonged, but it may not be factor 5 deficiency? So you do factor 8 because there is another condition which is called combined factor 5 and 8 deficiency. These are definitely rare clotting factor deficiencies, but they are there. So you go ahead, you don't give a misdiagnosis to the patient. Whenever you get a PT, APTT prolonged, and you get 5, you do the common pathway factors, you get 5 deficiency, but you do factor 8 as well because you have a condition called combined factor 5 and 8 deficiency. All these rare factors, they are present in both male and females. So this is very important. Otherwise, you say that you got 1 factor deficiency and you would stop there. But whenever you get 5 deficiency, go ahead and do factor 8 as well. Now coming to case 3, a 23-year-old man presented with prolonged bleed during a dental extraction. So he was diagnosed at the age of 23 with 1 episode of prolonged bleed in the past from a wound. So he has repeated bleeding during some invasive minor accidents. We did his initial PT, APTT, TT, factor 13, platelets, platelet function test. Everything is normal. So are you going to give a report saying that it's a normal study, or you are going to go ahead doing some more tests? We went ahead and we did the commonest factor, factor 8, 24%. Are you going to stop here? So whenever you get a factor 8 deficient, go ahead and do the VWF antigen as well. So you have a diagnosis of type 1 VWD, that is mild von Willebrand disease. Now the reason for me to put this is, if you go back and see his APTT is well within the normal range, 32 control, patient 34. So considering the APTT normal, what I want to stress here is, even when the APTT is normal, if the patient has a definitive bleeding history, please go ahead and do the factor 8, because in many of the cases, depending on other factors, some of the patients, 20% of the factor 8 may not show up in the APTT. In some cases, it may be above 30%. So all these depend on the individual, rest of the factors, because they compensate for APTT. So you should not be, whenever a patient comes to you for a complete coagulation workup, please look into the bleeding history. If there is a definitive bleeding history, even if the screening coagulation tests are normal, go ahead and do the factors, at least the common factors, like the way we caught up the diagnosis here. And whenever you get a factor VIII deficiency, rule out or include the diagnosis of von Willebrand disease. Now, this is a case of 23-day-old neonate presented with prolonged PT, APTT, and with IC bleed. There is no family history, born of non-consanguineous marriage. So looking at the PT, APTT values, which is both are prolonged, they asked us to do the factor assays. We repeated and we got somewhat similar results. PT, APTT prolonged, thrombin time normal. So it is nothing related to the inaccurate sample. So which factors are you going to do? PT, APTT. So you did, because it's a neonate, I'm not considering only the common pathway here. Because it's a 24-day neonate, first thing, the commonest thing what you see in a neonate is a vitamin K dependent factor deficiency. So we did a factor 10 here, which is less than 1, factor 9, suspecting vitamin K dependent. I didn't go ahead with the factor 5 like the earlier case. We did a factor 9, which is 2%. So immediately I can give a diagnosis of vitamin K dependent factor deficiency. Now, when I say vitamin K, very rarely it can be congenital, but the most commonest one is the acquired vitamin K dependent factor deficiency. So instead of what we do is we generally advise to go on vitamin K infusion injections with the advice of a hematologist. After 3 days, you come back and get the screening coagulations done. So most of the cases, they get normalized. They may not get totally normalized. There may be a borderline prolongation, which is normal for a neonate. The neonates have all factors on the lower side, especially the vitamin K dependent factors. So you won't get PT, APTT values as normal as an adult value. Okay, so you just call the child again after 3 months just to be on the safer side, because there is something called as congenital vitamin K dependent factor deficiency. And you repeat and say that everything is normal and it was an acquired vitamin K dependent factor deficiency. So in some of the cases, what we do, I mean, if you don't want to do a factor VIII, when a neonate comes to you with prolonged PT and APTT, if you do not want to, if you want to be cost effective, what you can do is, because the commonest thing what you see is a vitamin K dependent factor deficiency, you get the screening test prolonged, then after you just ask them to go for, you don't have to do the factors, suspecting acquired vitamin K factor deficiency. You just ask them to take injection and ask them to come and repeat it. And when it comes normal, you can give a diagnosis of acquired vitamin K dependent factor deficiency. So you repeat, and if it doesn't get corrected after 3 months, then you can give a diagnosis of congenital multiple coagulation factor deficiency, and they should be going further for genetic investigations to confirm, to further confirm the diagnosis of congenital vitamin K dependent coagulation factor deficiency. Now here, a 26-day-old neonate born of consanguinity presented with patches all over the body and a massive hematoma in the right thigh, transfused with fresh frozen plasma a week earlier. Everything is normal. 13-18 is normal. 32-38 is okay. Thrombin time is normal. What should be the next step? There is a definitive history of bleeding here. There is a hematoma, patches all over the body, first degree consanguinity, and the child was transfused. Platelet function normal. Your urea clot lysis was normal as well. But since the child was transfused with the blood, with the fresh frozen plasma, so his factor 13 ELISA came 22%. So what we do, the urea clot lysis, it can detect only severe factor 13 deficiencies. And if a child is transfused, you might miss the diagnosis by doing this test. The ELISA can detect these mild deficiency cases. So after 1 month, and factor 13 has got a long half-life. So you need to wait for a month before you do the test to get the basal levels. So repeat the investigations at least after a month, distant from transfusion, and you get factor 13. If it's a congenital deficiency, you get factor 13 less than 1. Case 6, this is all about neonates because many of the patients are misdiagnosed because of all these erratic values in the neonate, prolonged values. A 12-day-old neonate presented with prolonged PT, APTT, markedly prolonged, massive hematoma in the abdomen, no family history, non-consanguineous parents. Request factor assays. So we did factor 8, it is less than 1, factor 9, 42, factor 5, 65. I said in a neonate, most of the vitamin K dependent factors are low. So you don't have to label him as factor 8 and 9 deficiency. Factor 9, 42% is pretty normal for a neonate. So you should be giving a diagnosis of, I'm putting all these cases because we get these cases labeled as factor 8 and factor 9 deficiencies. Everybody should be aware of the fact that till about 3 months of age, the factor levels don't reach the normal adult values. Case 7, you have all 3 prolonged. An 8-year-old boy presented with prolonged history of bleed. There's no family history, first degree parental consanguinity. All 3 prolonged. Fibrinogen less than 10, because when all 3 are prolonged, you suspect fibrinogen deficiencies and case of afibrinogenemia. The diagnosis is given. Case 8, a 12-year-old girl presented with excessive menorrhagia. All 3 prolonged, fibrinogen less than 10. Diagnosis should be afibrinogenemia. The reason I'm putting the same type of laboratory picture again is when you do a factor 8 assay, every factor is low. So the interpretation should be inaccurate sample. What I'm saying is, this is a classical picture of afibrinogenemia, but there may be some clot because of the inaccurate mixing or sample collection, delayed sample mixing. So you should be having one normal parameter when you give a final result to the patient. Now, if you see here, a clotted sample will also give you similar picture. There is no parameter which is normal here. So you go ahead, I don't know how many labs will be able to do this. Excuse me. So you have to have one parameter, then only you can be confident to label this girl as afibrinogenemia. Need to be extremely cautious because sometimes the clot may not be visible. There may be a minute clot which may be prolonging all these clot timings. So the interpretation, inaccurate sample, and you need to ask for a fresh sample again. A 12-year-old girl, all these are the actual cases what we have seen in the lab, referred from Punjab, 4th girl in the family of 5 children, complaining of spontaneous ear bleed, bleed from eyes, very unusual bleeding manifestation, and epistaxis since 2 years, which generally coincides with her periods. There's no family history or prior history of bleeding. And when she was checked earlier, this was referred to us from Lilavati Hospital, and they gave a very detailed history. This history is extremely important. 4th girl in the family of 5 children. And we did all the investigations. Everything is normal, but the history is very strong of having a bleeding disorder. The symptoms were little suspicious to us. The girl was questioned repeatedly. Her parents were sent out, and the girl was repeatedly asked about the suspicion about the clinical manifestations. And after that, she confided that she had some problem, some attention deficit, and she used to put menstrual blood to show that she has some bleeding issues. As per her statement, she was being neglected after the boy was born in the family. So you can get such cases too, because all patients presented with bleeding in your lab may not be really. So you need to have a good history of the patient before you go ahead with all sorts of investigations. Once, of course, you need to do the basic investigations before you question the patient. This is a 45-year-old lady with dilated cardiomyopathy, no history of bleeding in the past. She required a pacemaker. Her APTT is not getting corrected at all because she's a lady, cardiomyopathy, and we can immediately suspect that she is a lupus. So you should be going for a lupus screen, and the lupus ratio will come above. It was 2.5, and the diagnosis of LA was given. So lady, the age, the kind of clinical manifestations will direct you to lupus confirmatory tests. Now, this is a female. Prior to her hysterectomy, there is no history of bleed. One of the labs got the APTT highly prolonged. Mixing is totally correcting, so lupus is ruled out. PT, APTT normal, all factors normal. Every factor related to APTT is normal. So what is the diagnosis? APTT is prolonged, but none of the factors, the mixing is getting corrected. So you are in a dilemma. So the sample was sent to us and we got normal study. We got the APTT as well, a normal 105 and 32. Difference, these are two labs in Bombay. One is ours and another one is a private lab in Bombay. We asked for a fresh sample again, the same thing. They did the test there and the sample was sent to us. The same thing happened. So what we did was incubation time was increased with the APTT reagent. We asked the lab to increase the incubation time, and then we found out that the APTT was normalized. So the first lab, whichever has done this test, their APTT was contact factor sensitive. So the APTT was prolonged, and when they incubated it further, the APTT was shortened. So this is a contact factor deficiency. And the second lab was using an APTT reagent, which was insensitive to contact factor. That is the reason they got the APTT normal, and the first lab got the, so the patient did not have any bleeding history as well, because the contact factors and factor 12 do not result in any bleeding. They just prolong your APTT. So there is a simple test you can increase. I mean, you generally have an APTT where you have to incubate with the plasma for 5 minutes or 3 minutes. You incubate, you increase the incubation time 3 times and your APTT gets normalized. This itself is a confirmatory test. You don't have to go for those expensive one-stage assay using factor 12 deficient plasma or contact factor deficient plasma. This itself will be sufficient. In the presence, in the absence of any bleeding history, you can give a diagnosis of contact factor or 12. Now, this is a 64-year-old man, ecchymotic patches, all of a sudden with hematoma, classical clinical manifestation of acquired hemophilia. Now, whenever you see the age-related and a sudden manifestation, your suspicion should be acquired hemophilia. And the same thing is being seen here. Rest of the factors normal. It is factor 8, 2%, and mixing study is not getting corrected at 0R itself. Bethesda assay is showing 14.6. Generally, the Bethesdas are not very accurate because you don't get linearity with the acquired type 2 type of inhibitors. Now, here a 16-year-old boy, born of consanguineous marriage, presented with severe epistaxis and prolonged bleed after dental extraction. There is a family history. The same problem is seen in his sister. Consanguinity, family history, both sexes affected, and a definitive bleeding history in the index case. PT normal, APTT is prolonged, thrombin time normal. So you go ahead with factor 8, factor 9 is normal, VWF is normal, RIPA, everything is normal. So it's only factor 8 is the abnormal value here. So is it a moderate hemophilia A? So I said whenever a factor 8 is low, you go for VWF. You have done that. VWF is normal. But the only indication here is his sister also has similar bleeding history. So there is one subtype of von Willebrand disease where, which you call as Normandy type 2 NVWD, where all VWF related investigations are normal. Antigen is normal, RIPA is normal. It's only factor 8 which is reduced. But there is one test which can confirm this apart from the genetic test, that is VWF factor 8 binding assay, which is 4%. Now here the only indication for us to, we would have easily labeled it as a moderate hemophilia A, because remember the treatment is totally different. The patient definitely needs a confirmed specific diagnosis. And here the binding assay says that the binding is only 4%. So it is a type 2 Normandy VWD. Now, if we did not have a female bleeder in the family, we would have easily labeled. Nobody goes for genetic diagnosis in all cases unless it's asked for. So this is a case of type 2 Normandy. Many of these type 2 Normandy cases are misdiagnosed as either moderate or mild von Willebrand, mild factor VIII deficiency, because all VWF investigations are normal, but you need to know about this subtype as well. This is one recent case. A 54-year-old patient comes to the laboratory with an APTT of 100 seconds, PT prolonged, factor 8 and 9 normal, no evidence of bleeding. Okay, I'm sorry. A 24-year-old patient was referred for a coagulation factor workup. PT is prolonged, APTT is marginally prolonged. Factor, all vitamin K depend, even factor 8 is slightly on the lower side. Liver function tests are normal. Lupus screening, we did a lupus screening, plasma is not clotting at all. How would you, because under these circumstances you look for, because he's a liver disease case, his liver function tests are normal. So what else? So you did a lupus screening to screen for lupus anticoagulants and you are getting the answer there. So he's got strong antiphospholipid antibodies, which is not allowing the plasma to clot. So when the antiphospholipid antibodies are too high or titer, you can get this picture. Your plasma doesn't clot at all. So final diagnosis would be strong LA, which has reduced all the factors. Thank you. Any questions?
Thank you, ma'am, for that excellent lecture. Now we will take questions. Any one of you here want to ask any questions? No. So now the chat box. Okay, ma'am, one question. For the contact factor deficiency detection, which APTT reagent to be used?
The one which was, I mean, I have one which was sensitive to the contact factors which was being used in NIH was at that time was Organon Technica. And he was using probably, I'm not sure, Siemens some reagent. I won't be able to tell you offhand about which reagent. I mean, if you can take the email, I can just put it across to her.
She's asking one more, whether it is LA insensitive or contact factor sensitive, the APTT reagent which is supposed to be used.
You don't get commercially a contact factor like how you get for lupus. sensitive, lupus insensitive. You don't get contact factor sensitive, contact factor insensitive. There is one paper of ours in blood coagulation and fibrinolysis, but offhand, I won't remember which reagent is insensitive to contact factor and which is sensitive to. But vaguely, I remember that time we were using Organon Technica, and probably it's not available at the moment in the market, but I'll definitely let her know in my email. I need to check that.
Yes, she sent her email. Ma'am, one more question. One second, it's going so fast. Okay. 1 second. We often get children who have mild recurrent mucosal bleeds for screening. We are doing PT, APT, 1 milligram antigen levels. Do you recommend that all such patients we do a urea clot lysis test also?
Yeah, urea clot lysis, whenever a child or an adult comes to you, I mean, it comes in the first primary screening test, PT, APTT, TT, factor 13, and yeah, so it comes in the primary. So you need to do it as a basic screening assay.
There is one more question. No, sorry.
But you might not pick up mild factor 13 by urea clot lysis. You may have to do an ELISA to get mild and moderate deficiency cases.
This question, ma'am, will answer in her next lecture. The question is, when are we expecting the kit-based test for VWD and hemophilia? That is the next talk.
That.
Yeah.
Sure.
And okay, I think we can move on to the next lecture. Okay, ma'am, 1 second. There is one question. 29-year female with history of repeated abortion has APTT around 41 to 45 seconds. No bleeding tendency. LA and ACLA antibodies are normal. CBC normal. PT and BT normal. How should we proceed?
45 seconds APTT is definitely prolonged. But again, even if she's deficient for any factor, it may not be a severe deficiency which can lead to recurrent fetal loss. First, you need to kind of identify, I mean, why the APTT is prolonged. As far as the fetal loss is concerned, the two main factors which are involved is factor 13 and fibrinogen. So you need to look into that. And other than that, because for recurrent fetal loss, there are multiple other factors. Is it coincidental finding of mild APTT prolongation? I'm not very sure about that. There should be a definitive history to go for. But 45 doesn't indicate any severe factor, but you need to explain your prolonged APTT. If the lupus is negative, is your lupus test kind of sensitive enough to pick up even the mild lupus anticoagulant? You need to first explain the APTT prolongation. And for recurrent fetal loss, there are multiple causes in the thrombophilia side. So you need to work on that. These are the two things I would say.
Okay. Okay. All right. I think we can move ahead with the next lecture, which is one of the most interesting lectures on point of care tests for bleeding disorders. A completely new aspect in coagulation, a concept thought of, acted on, and a POC developed by Dr. Shrimati Shetty.
Thank you, Rucha.
Yes.
You can see the slides, right?
Yes, ma'am.
All right. This is point of care test for bleeding disorders, which we have developed at ICMR NIIH. We have developed it for the two commonest bleeding disorders, that is hemophilia A and von Willebrand disease. Now, why do we need a POC test? We have an anticipated number of around 100,000 hemophilia patients in the country. But till date, we have only about 25,000 plus patients registered with HFI India. So it only says that 70 to 80% of the patients are undiagnosed till date. We know that majority of the patients of VWD are undiagnosed or misdiagnosed in India because most of the labs do not have, they may have factor assay facilities, but they do not have VWF antigen testing facility. So there is definitely a need of simple tests for diagnosis for these two commonest bleeding disorders. Now, what is a point of care test? It's a diagnostic test at or near the site of the patient. Can be done by even untrained personnel. There's no requirement of expensive equipment and rapid turnaround time, rapid generation of the results. It's not that we don't have any point of care test throughout the world for PT, PT-INR, APTT, ACT, thrombin T. Then we have the machine-based, they are also called POC tests, TEG, ROTEM, PFA 100, and D-dimer. These are the ones reported in the world literature so far, the POC tests, what we have. And these are the pictures of some of the POC tests, what we have. I don't think it's widely being used in our country. These are the machine-based POC tests, TEG, ROTEM, and platelet function analyzer down. Now let me come to the most important thing, what we have developed at NIIH, that is for hemophilia A and von Willebrand disease. Why we took VWD and HA? Because these are the two commonest ones everybody knows. And when I say 100,000, it may not be just restricted to 100,000. The number of assays we do are many-fold more than the actual number of patients diagnosed. There is a lack of awareness, shortage of diagnostic labs. And we also know that the reagents what we use are pretty expensive. There's lack of technical expertise and sophisticated instruments we need for these assays. Very few diagnostic laboratories do comprehensive workup for a bleeding disorder. And quite a few HA patients have been misdiagnosed as von Willebrand or vice versa. So development of a point of care test is the need for this country or to many of the developing countries. Now, when we develop a POC test for hemophilia or von Willebrand disease, there should be a definite specific cutoff level, because you may have seen the POC test for infectious diseases like dengue, HIV, many other diseases where it is just yes or no, the dengue present or absent. But in case of hemophilia, you need to have a cutoff level. It can be less than 1 or it can be less than 5. So we thought we should stick to less than 5 because these are clinically significant bleeder group. So this is how we proceeded. And this is Priyanka, who has worked for both these kits. Now this is how it looks like. You all may be familiar with this POC kits. You have a control line all the time. It should work to say that your test has worked well. And your test line can have the line present or absent. If it's present, it's a normal, or if it's absent, you have to interpret that this is a patient sample with less than 5% factor 8 or VWF. So when you have the line, it can be a normal or it can be a mild factor 8 deficiency. The intensity will vaguely tell you as what it is. A lot of work has gone. The test is simple, but designing this test is very complex. A lot of work has gone. There is it's a gold nanoparticle labeled test, and the size, the shape of the gold particles are extremely important. This has been done with the help of IIT Mumbai and UDCT Matunga, because all these facilities we do not have at NIH, the nanotechnology. So they have helped us in getting this done. And this is how it looks like. You have two kits. You take one normal plasma and a citrated plasma. This is the empty strip fully loaded with the antibody membranes. And you take a strip, add 50 microliter of your normal plasma. Take another strip, add 50 microliter of patient plasma. This is how a normal strip looks like, and this is how a patient, a severe or moderate hemophilia will. You don't have any line in the test. Pretty simple, 10 minutes test. You don't need any machine. The diagnosis can be given anywhere, in any place, as long as you have the plasma with you. So the final standardized thing is for HA, the detection time, you load the plasma. Srinath, am I disturbing you?
No, am I disturbing you?
Not at all. I'm sorry. Okay. Now, so for HA, it is 10 minutes and VWD, it is 15 minutes observation time. The sample volume is, this is how it has been standardized. So even a pediatric sample, you can just load the sample, and this is the storage, 4 to 30 degrees. And stability for hemophilia, we have checked for 1 year, and for von Willebrand disease, we have checked for 2 years. I will not get into the statistics of validation data. We have checked at NIH ICMR. This is the company, NIH BBI, and then GS Medical. And this is all false sensitivity and specificity, true positive, which is actually required while giving the data to DCGI. This is, we have also sent to 2 people abroad, Pierre Toulon from France and Steve Kitchen, who is a well-known quality control person of World Federation of Hemophilia. We all have got good acceptable inputs from them. KEM Hospital, CMC Vellore, All India Institute of Medical Sciences. We have sent only to the labs where we have a comprehensive diagnostic facilities, for the simple reason they get enough patients to give us the feedback within a shorter time. Now, what important point you have to keep in mind is clinical correlation, which is, of course, even when you do a factor VIII assay, you have to take the detail as whether the patient has been transfused, so that you do not give a misdiagnosis. Volume of plasma, what you add to these strips, is extremely important, because you should not be adding more plasma. Your pipette should be well calibrated. And the observation time, the results, what you interpret. When I say, I give a window time 10 to 15 minutes, it should be observed within 10 to 15 minutes. So that, because if you, instead of 10 to 15 minutes, if you observe it in 25 minutes or 30 minutes, you may get false positive results. This is same for any of the other lateral flow immunoassay based kits. Now, this is a company, Bhatt Biotech India in Bangalore, with whom ICMR signed a memorandum of understanding, and they have prepared these kits, and very soon it will be in the market. Now, the various processes we have gone through before bringing into the market, we had an internal validation, external validation with all the premier institutes in the country. We have applied for the patent, the national patent. The complete application is under process. The international patent we have applied to US and South Africa. This was decided. Now, why these 2 states? I mean, countries. So this was decided at ICMR. We may extend it to other countries as well at a later stage. Commercialization process of this IVD in vitro diagnostic kit is, first the MOU was signed, then a provisional test license was obtained by the company by applying to DCGI. 3 batches were sent for validation, and the final report was sent to DCGI. And we just obtained the manufacturing license. The final one the company got on 17th of April 22, which was the World Hemophilia Day. So with all these, now the kit should be there for common man use in the next 2 to 3 months. I'm very happy to announce that. Now the cost, which is extremely important. Hemophilia A kit, this is the proposed cost given by the company. A pack of 10 test kits is costing 3,000 rupees. I'm sure for factor assay, many of the private labs, for one assay, they must be charging 3,000 rupees. But here it's 10 tests. It is 200 per test. The final billing price is 200 for a factor VIII diagnosis. And for VWF, many of the labs private labs are even charging up to 8,000. Here it is just 70 rupees per test. Now, why the factor VIII kit is costing a little more, 200? Because the antibodies are a little more expensive than the VWF antibody. Now, this is the first release cost. I'm sure as the company gets some discount for bulk volume purchase, they will come down in the cost. Now, we want to do further modifications. We want to bring these plasma-based kits to market as early as possible, probably in the next 2 to 3 months. But we also want to make things much easier for the users. We want to bring the whole blood kits. We don't want to separate the plasma because many of the primary healthcare centers may not even have a centrifuge to use to separate the plasma. So these are some of the proposed modifications which we are in continuous touch with the technical group of the company. We want to bring it for whole blood. We want to do a quantitation of the factor 8 or VWF. We want to see whether finger prick samples are okay. We also want to see whether factor 8 and VWF can be detected in the same kit. These are some of the proposed modifications which we want the company to develop. So the quantification, there are different LFI strip readers. We need to validate again. The company cannot directly put it to the market, but whether we can use these LFI readers, whether there can be a smartphone based the quantitation. These are all which we need to, but our first objective is to bring the plasma based kit to the market. Now, whole blood kit, the company is already working. They are working very beautifully. You can see the bands here. So they need some special filters to filter the red blood cells here, which they've used. So the cost may be 20 to 25% more than the plasma based kit. This is the combo kit, which I said is you have on either side, you have both, because when a hemophilia A patient comes, you need to rule out VWD. When a VWD patient comes to you, you want to know the factor 8 levels. So both these tests you need in all the patients, all hemophilia and von Willebrand. So you have a multiplex. This is already established by the company. Whole blood is established. It is only the quantitation which we need to see. So acknowledgements are to these two institutes because they have helped in the initial standardization. Thank you. Questions?
Yes, thank you, ma'am. I'm sure everyone has questions. Now we'll go to the questions right now. Anyone has questions here? Yes, so there were two questions about when are these kits going to come commercially, but they got the answer in your presentation. So that is done. Ma'am, I'm going to ask you one question on the previous lecture. Someone had put it later on. So 45-year-old female with bleeding, inhibitor presentation on screening. Shall we do a Bethesda or Apla? Which one first?
She is a female. She cannot be hemophilia. So most likely to be lupus. So they have to go for Apla, lupus and other things. She doesn't have a bleeding history. So whenever a female presents with the sudden bleeding, I mean, you have to see that time of manifestation also. She has bleeding, you said, did you?
Yes, with bleeding.
With bleeding, then she needs to be worked up for von Willebrand. What is the APTT?
No, not given. He's not mentioned.
You need to see. Okay. No, what is the question you said? Read it again.
45-year female with bleeding. He's written right now, APTT is prolonged.
Okay, if 45-year-old lady with bleeding, so you need to do the usual workup. Is she a case of von Willebrand disease? APTT is prolonged. So the first thing to do is to do a VWD workup. She's a female. If the rest of the tests are normal, PT and TT are normal, the first thing to go when APTT and it's with the bleeding. So probably you need to do a mixing studies in all cases, whatever bleeding or thrombosis. And then you go further for a VWD workup.
He's just meant inhibitor present on mixing, the immediate mix.
So it's likely to be lupus. There are very rare instances of lupus related bleeding, especially when it reduces factor 2. So I'm not very sure whether it's a case of factor, because when you have lupus, see, is she a case of VWF inhibitor? That is another thing. You need to do a complete workup. APTT prolonged, mixing, not correcting, a lady presenting with bleeding. So the possibilities are, is it an acquired von Willebrand disease? because inhibitor, I'm not saying it's congenital because of the inhibitor. Or is it a congenital von Willebrand disease with inhibitor? Or is it a lupus related? You need to do both factor VIII, VWF, lupus to have the complete picture.
One more question. What should be the interval between running a POC test and transfusion of blood products?
If you are running for factor VIII, generally it depends on how much factor you need to work the half-life, and probably 3 to 4 days should be ideal before you run a POC. See, POC can detect anything less than 5%, it comes blank in the test line. Anything more than 5%, it comes a faint line depending on the factor level. So like how you do factor VIII assays, the principle remains the same. You need to give 3 to 4 days before you go for whether it's one stage assay or a POC, it remains the same.
Next question. Ma'am, for diagnosis of von Willebrand disease, except 2N, is only von Willebrand antigen level sufficient or activity assays are needed to make a diagnosis? And do we also need to do a factor VIII in all such cases, even in females?
Yes, factor VIII needs to be done in all cases of von Willebrand disease. Now, whether we need to do type 2 VWD, many of the labs are missing. Now, in case of, this should be like a screening assay. Whenever a patient presents to you with the bleeding, you get all tests normal. Type 2 workup is extremely important, especially the VWF recough, because otherwise you'll miss, because your antigen is normal. So how will you pick up the functional variant? We have 25 to 30% of the VWD cases are type 2. So to pick up those, it is not only type 2N, rest of the variants, 2A, 2M, 2B. I mean, you need to do, even the low dose ristocetin you need to do, whether this is a case of type 2B von Willebrand disease. And recough should be done as a screening assay in case of definitive bleeding history, because otherwise you'll miss this case, the diagnosis.
Okay, thank you. I think the questions are done. So thank you, ma'am, for this amazing lecture. I would like to propose a hearty vote of thanks to you. And we look forward to many such interactions. Thank you so much. And you have excellent comments coming over here, like this POC test is a revolutionary step and everything. So you may check the chat box for the same.
Thank you. Thank you. All right.
I now request Dr. Bipin Kulkarni to to deliver the vote of thanks.
Thank you so much, Shrimati. It was a wonderful lecture as always.
I feel so good to see you all.
Yeah, it's okay now. So with that, we come to the end of the lecture series in this workshop. And I can say that the workshop was definitely very successful. We had well over 300 total registered participants in this lecture series workshop. And this was mainly because of the topics and the orators that we had. And we are extremely thankful to all the eminent orators that we had for this workshop. I sincerely thank all of them, Dr. Sukesh Nair, Dr. Prantar Chakrabarti, Dr. Shrimati Shetty, Dr. Jasmina Aluwalia, and Dr. Chandrakala for sharing their valuable knowledge and time with us. And we hope to interact with you and keep interacting in the future with all these workshops and meetings. I thank our director, Dr. Manisha, for supporting us to conduct this workshop. I also thank Mr. Chittaranjan Das of HFI Bhubaneswar, who actually got in touch with us and requested us to conduct a workshop, and that's how it all started. I thank all the participants who came down here physically for the hands-on session. of course, my colleagues and staff, Dr. Rucha is here, and everyone in my department who have contributed for making this workshop successful. And I'm very sure that the lecture series has helped us better our understanding of laboratory hemostasis. So with that, we conclude the lecture series, and I thank you one and all once again.